Good afternoon, and welcome to today's webinar, HIV Linkage to Care and Overdose Prevention for People Returning to the Community After Incarceration. We're excited to see so many joining us from all over today as we discuss the many intersections of HIV prevention and treatment, overdose prevention, and incarceration. Give you a heads up before we get started that this webinar is being recorded. The slides, handouts, and recording will be made available next week at our website, aidsunited.org/webinars. And for folks on the phone, this webinar is in listen-only mode. So to ask a question, please use the Q&A box in the lower right of your screen. Audio information for you to call in on your phone is provided in the right column, right above the Q&A. And you can also listen through your computer speakers if you're not on the phone. As we go throughout the webinar, feel free to add your questions throughout, and we will get to them during the Q&A period during the last 30 minutes of the webinar. And for those questions we don't get a chance to answer, we'll post the answers to those questions along with the webinar recording next week at aidsunited.org/webinars. Also, we are so incredibly excited to offer closed captioning on this webinar. So for those who are using the closed captioning pod, you can find the text box below the main slides. In this pod, you can customize the text appearance, the size of the text, and even search for keywords. You can also minimize the menu by clicking the arrow in the middle of the pod, but this is here for folks who may need to use any sort of closed captioning services during the webinar. All right, so just to start us off, my name is Emmett Patterson, and I'm a capacity building specialist here at AIDS United, and I'm thrilled to be joined by the most wonderful group of presenters today from around the country. So first up, we have Katie Kramer and Barry Zach from the Bridging Group. Founded in 2008, the Bridging Group has provided training, technical assistance, and evaluation and research for governmental, non-governmental organizations, and research and academic institutions working in correctional facilities and in community reentry across the United States and the world. And also joining us today, we have Emma Roberts, Director of Capacity Building Services from the Harm Reduction Coalition. The Capacity Building Services team at Harm Reduction Coalition have been providing training and TA services nationwide for over 20 years on harm reduction, drug user health, and other related topics. Central to their work is the focus that Harm Reduction Coalition creates spaces for dialogue and action to help heal the harms of racialized drug policies. And finally, we have Ms. Michelle McElroy, current Deputy Executive Director for the Southern Tier AIDS Program. She's worked at the Southern Tier AIDS Program for over 11 years, performing roles related to direct service, administration, harm reduction services and education, advocacy, and grant writing. Her previous work focused on individuals with mental health or co-occurring disorders in a residential setting. She's a graduate from the UCLA Healthcare Executive Leadership Program of 2015, and she has worked in human services for more than 20 years. Ms. McElroy has served on several New York State Department of Health work groups and has recently been offering assistance to newly funded drug user health hub programs throughout New York State, based on the pilot started at Southern Tier AIDS Program in 2016. She is a believer in the power of each person to achieve positive change through the application of harm reduction principles and the achievement of small successes. So thanks to all of our phenomenally talented presenters who are joining us today. And before we get started, for people who may not be familiar with AIDS United, AIDS United's mission is to end the AIDS epidemic in the United States through strategic grant making, capacity building, policy and advocacy, technical assistance, and formative research. We're based in Washington, D.C., but have a national scope. And as I mentioned earlier, I am a part of AIDS United's capacity building program, Getting to Zero. We work in partnership with the Harm Reduction Coalition and the Bridging Group, two of our wonderful presenters on the line today, to provide free technical assistance and training to community-based organizations across the country. We offer tailored, result-oriented assistance focused on strengthening HIV prevention efforts among people living with and at high risk for contracting HIV, organizational and program development best practices to improve impact and sustainability, and offering assistance around evidence-based interventions, most specifically Willow, Project Start Plus, which you'll hear about in just a little bit, and healthy relationships. And if you're interested, you can find out more about us at ceba@aidsunited.org. All right. Well, before we get started in some of the webinar content, we did want to hear a little bit about who is in the room today. So I am opening a poll on your main screen, and I'm going to give everyone in the room just a few seconds. You already are all doing it. You're rock stars. You've been on webinars before. Great. Please select any and all that apply to you. What kind of work are you currently doing? So if you're working inside correctional facilities, providing reentry services, or providing overdose prevention, or none of the above, just kind of let us know who's in the room. And I'm just going to give it a few more seconds. All right. All right. Looks like we've got quite a bit of folks who are currently providing harm reduction or reentry services. Next up, we've got folks working inside correctional facilities. Okay. Folks returning home after incarceration. Okay, so it's a pretty good mix of folks. I know that today you're going to hear so many amazing ideas and new models that are coming out. So thank you so much for allowing us to get to know you a little better. And now, just wanted to give us a little bit of an understanding of what we'll be covering today. So, on this webinar, participants will walk away, number one, understanding the link between HIV and overdose risk involved in the criminal justice system. On this webinar, you'll also obtain information about innovative approaches for integrating harm reduction and overdose planning into linkage to care programs. And finally, you'll hear from community stakeholders about successful strategies for building effective partnerships that support linkage and overdose prevention. All right, so I am going to now pass it over to Barry Zach. So Barry, go ahead and take it away.
Thank you very much. And I want to just thank everybody for calling in and your interest in this critically important topic. I'm going to present some data, some hard data, to really frame the issue. This will help improve our understanding of its importance, as well as help us, write those grants and support our program efforts. So with that, let's look at just the U.S. incarceration rates. The bottom line is we incarcerate more people in the United States than anywhere else in the world. We incarcerate over 25% of all people who are incarcerated worldwide, and with that, over-representation of people of color. And that's both when we talk about incarceration, we talk about both behind bars as well as beyond incarceration being monitored, meaning on probation or parole. When we look at HIV and incarceration, again, we're talking about something with the burden of infectious diseases, the burden of HIV. The prevalence is 2.5 times the national rate of people who are inside prisons and jails. And we're talking about over 155,000 people living with HIV are released from prison or jail every year. Now, the gamut of care and treatment in corrections, really runs the gamut from, I don't want to say, nothing to close to nothing to real comprehensive care and treatment. What we have learned is that for those people who have maintained viral suppression during their incarceration, upon release, they're less likely to maintain viral suppression, and they're more likely to use an emergency room for medical care upon release. Continuing like this reality check of the burden of HIV within this population, it's estimated that each year 14 to 25% of all people living with HIV in the U.S. spend some time in prison or jail. So, if that's, without that, I mean, if we don't target this population, I wonder how much of a malpractice we're really, conducting here. When you look at a quarter of all people with one infection can be found in the prison or jail during a course of a year. So this really justifies the efforts that we're all doing with this population. Hepatitis C, again, HCV rates in the prisons and jails are, plus 17%, and then chronic infection is between 12 and 35%. So again, an overrepresentation of this population in the criminal justice system. When we talk about, we're talking about infectious, I mean, we talk about HIV, HCV, we can talk about other STDs, syphilis, gonorrhea, chlamydia, all have an overrepresentation, increased burden in the prisons and jails than in the community. Tuberculosis, hepatitis B as well. Chronic conditions, again, we're talking about overweight, obesity, diabetes, hypertension, i.e. high blood pressure, again, and with the aging population because of the sentencing policies here in the United States, people are doing more time and people are aging inside. So these chronic conditions are also increasing at a much faster and higher rate. Moving to mental illness and substance use disorders in the population, we're seeing, again, an increased burden of disease within the population with mental illness, serious mental illness, substance use disorders. You know, we're talking about over 70% of people with serious mental illness also have a substance use disorder. And I would say of upwards of 80% of people who are incarcerated have history of mental illness and or substance use disorders. Again, another reason why we need to, work with this population both inside and upon their release from custody. Now, a lot of people, there's a myth out there, dare I say, that people go into prison and jail healthy and come out sick. And I just want to make it really, really clear that there's no data whatsoever to support that, actually just the opposite. Most people come into prison and jail already sick, already infected with whether it be an infectious disease or with a chronic condition. The behaviors that people engage in on the outside continue on the inside. Yes, nobody is saying that. No, people don't have sex or don't inject drugs. Tattooing, body piercing, you can see the list on the inside. But again, the infection rates are really show the people coming in with it, not upon release. When we look at apologies here. There we go. When we talk about the risks of upon reentry, a study that was done not too long ago in Washington State really looked at morbidity upon release from custody, and we really see they looked at over 57,000 person years, over 30,000 unique individuals. And the outcomes, sadly, are not just astonishing, but they've been replicated in other countries and other jurisdictions in the United States. And what we see here is really the mortality rates upon release from prison. And this was a prison study. And you can see just people were 13 times more likely to die within the first 2 weeks of release from custody. And that was 3.5 times greater than the overall adjusted community mortality rate. The red line there is the community mortality rate of what dare I say, what could be expected. As far as the causes of death with this cohort, you can see that the overdose was someone, relative risk is like an odds ratio, meaning that someone is more than 12 times likely to die from an overdose within the first 2 weeks of release than somebody in the community. And you can see the other causes were heart disease, cardiovascular disease, homicide 10 times more likely, suicide 3 times more likely. So what does that teach us? That people getting out of prison are at increased risk for death. The risk is greatest amongst the 2 weeks after release. I'm really focusing on this because this was really informing us how critically important it is to work with people, I would say pre-release from custody, and you'll learn more about that with when Katie talks about Project Start Plus, as well as how important it is to continue in that immediate release time period to deal with both linkage to care and risk reduction. Again, the highest risk of death is from overdose, cardiovascular disease, homicide, and suicide. And as I mentioned, this is being replicated. We're seeing this, people being released from prison in Europe and Australia and other jurisdictions in the United States. You know, a lot of times people think, you know, when you're doing time and you're in. And for those of us working with this population, we just see how much movement there is from the community to the court to the jail to prison, back to court, back to jail. So it never really is, unless someone has really been sentenced to some serious time in state or federal bureau of prisons into that system. There's a lot of movement in and out of the community. We can have a large conversation about technical violations, people coming in and out, not as a result of a new crime, but as a result of a violation of their parole conditions. That's something that's critically important for those people working in reentry to really look at and focus on, to really understand the context of what are the conditions of parole of my client, so I could help him or her work with, successfully link to care and work with them when they get out of jail and or prison. So in wrapping up, you know, this sort of introductory piece with some lessons learned, you know, this is the prison and jail, the correctional setting. And many times this is the only place where people receive care, treatment, and support. This is where people are being diagnosed. This is where people are being treated. This is where also, you know, the support system is for many people. It's not on the outside. So that's a real statement on the lack of community support and care on the outside. People come into prison jail with higher rates of infectious disease and chronic conditions. And let's also, another reality check, over 95% of people who are incarcerated do return to the community, do come out. When we look at the Linkages Challenges, when we talk about, you know, getting out of prison, jail, and community health, you know, there's lots of things that we can be doing. But I want everyone to focus on the last point under the release, making reentry work. The last point there is addressing life's competing priorities. This is really a priority, one of the key variables of Project Start Plus, which you'll be hearing about, as well as other effective reentry interventions. Sometimes our funding or, you know, whatever tells us we're disease specific or we're topic specific, but we really need to look at the whole person. We really need to look at all of the competing priorities. Somebody who doesn't know where they're going to sleep the night they get out of prison, medication adherence is not their number one priority. It's where am I going to sleep when I get out. So it's really looking at all those other life priorities. And we can spend a week on this one dynamic here of these linkages challenges, from practical downstream to the upstream policy on sentencing, drugs, housing, and immigration. All really, really important issues that we also have to tackle. So in closing, you know, you talk about prison and community health. You know, most people in prison get out, over 95%. Overall, this population is unhealthy relatively to the free community on the outside. People come into prison with higher rates of hepatitis, HIV, STDs, TB, hypertension, diabetes, and again, we're going to be seeing that as the population gets older. And what we're all here about is that, you know, prison public health programs represent access to this population to improve community health. We also do have data that if you can improve prison jail health, that also improves community health. So with that, I'm going to pass this over to Katie, who's going to talk real specifically about one of the interventions that has been shown to be effective in making this link work. Thank you very much.
Great, thank you, Barry. And as Barry mentioned, I'm going to spend some time talking a bit more about linkage to care programs for people living with HIV who are returning to the community after incarceration, and how can we integrate harm reduction and overdose planning into these programs. So we know as people who are living with HIV prepare to leave prison or jail, they will likely have HIV-related needs. And that may be a combination of looking to link with a medical provider in the community, That medical provider may be someone that they were seeing before they were incarcerated. It may be that a new medical provider is needed, that the provider they were with before isn't working with them, didn't work well with them, they've moved to another, being released to another community, that provider no longer is available. It may also be, and I think this is very key as we look at linkage to care, for an individual who has been newly diagnosed for the first time while they were just incarcerated. This is a time when this individual will be looking to figure out how to live with HIV in the community, which could look very different from how they've adapted living with HIV while they were incarcerated. So for those individuals, it's linking them to a medical provider in the community for the first time. They may also have needs related to medication use and adherence. That's a combination of where and how do I get a prescription, how do I get that prescription filled, if there's a copay, what kind of money do I have to pay for that, and medication adherence. And again, this looks very different in the community than it does in a correctional setting. In the correctional setting, most often medication use is very regulated, and that folks, and helping them to plan what will life look like in terms of having more power and control and responsibility over my own medication use and schedule. Folks may also have needs in enrolling in Medicaid or other insurance programs and enrolling in ADAP, or the AIDS Drug Assistance Program, upon release. They have needs maybe in gathering paperwork and medical records from correctional facilities to the community. This can be notoriously complicated and challenging. Most often, medical providers in a correctional facility are not linked to medical providers in the community. So how does the information, the medical records from inside the prison or jail get transferred to the community, or are we in the process of starting over? And then looking at behavioral risk assessment in the context of someone living with HIV. And again, this may look very different for somebody who's been living with HIV for a long time and has been in and out of prison or jail versus somebody who's newly diagnosed for the first time and looking to plan how their behaviors in the community will be impacted by their new HIV status. And we also know that individuals, when they get out of prison or jail, have a lot more going on than just taking care of their HIV medical needs. For many people, it is a #1 priority to find a job and employment. It can be about finding housing, whether that's immediate released housing or long-term housing. It can be about an identification, getting an ID, which often is the gateway to everything else that folks may need. For some folks, it's about the most immediate needs around food, clothing, shelter. It can be about educational needs and goals, family support, child care. Often, it's about checking in with parole or probation and learning the conditions of parole or probation and how to sustain those. Substance use disorder treatments, mental health counseling, other legal issues, dental care. Indeed, life can be complicated when people get out. And as Barry mentioned, often there could be much more pressing immediate life needs that will be prioritized for an individual over their HIV care. I, again, talked briefly about that, as did Emmett. I want to recognize, I know we have folks on the line and in the webinar who are implementing Project Start Plus in the field, so I just want to recognize them and commend them for the hard and important work they're doing. Project Start Plus is a linkage to care and risk reduction program for people living with HIV, returning to the community after incarceration. It originated through a CDC-funded research project, and along the way was adapted specifically for people living with HIV. One important note is that it was the first of its kind within the world of CDC of a linkage to care or reentry program that was established and developed from the very beginning specifically for folks in correctional settings. And that's unique in that often programs, linkage to care or HIV prevention programs are programs that were developed in the community and adapted for the correctional setting, or reentry programs that were developed for the reentry setting are then adapted for folks living with HIV. But Project Start Plus from the very beginning was a program designed very specifically and targeted for folks in the correctional setting returning to the community after release. It is currently an intervention that is funded by the Centers for Disease Control. It's also funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, as well as many state health departments. So in brief, Project START Plus serves as a bridge to success. It is intentionally a short-term, multi-session program that works one-on-one with the individuals. It's not a group-level intervention. It's an individual, pretty intensive intervention. And again, it serves as this really unique bridge from the inside out. As Barry mentioned earlier, it is intentionally a program that starts when folks are still incarcerated on the inside with enrollment and 2 pretty intensive pre-release sessions, and then works with folks for 3 months post-release with 4 continued one-on-one sessions. It is short-term. It does not intend to replace longer-term systems of care, but really be that intensive bridge to help with folks as they're adjusting from incarceration back into the community and to link them with longer-term resources in their home communities. The preliminary activities of Project START Plus include a pretty comprehensive assessment process, which includes 3 comprehensive assessment tools. One is a very specific linkage to care assessment. This assessment looks, as I mentioned earlier, at both people's experience in care and medication prior to their current incarceration, during their current incarceration, and as they get ready to go home. It's very important to work with folks who are in correctional settings to talk a bit about what happened if they knew their HIV status before they were incarcerated, because that may help to guide what may likely happen when they get out. The next assessment is a behavioral risk assessment that has been adapted specifically for people living with HIV, again in the context of reentry. And then finally, there's this comprehensive needs assessment, and this is the assessment that really gets into all those other life needs. So there's areas that look at housing and employment and substance use, mental health care, family issues. So it goes into that assessment of all those other life needs. From these assessments, we help the individuals develop personalized goal sheets. The goal sheets are very intentionally, very simple tools. They replace these kind of longer care plans that are used by other programs, but they are individually driven, and they really look at goals around linkage to care, risk assessment, and reentry needs assessment. Unique to Project START Plus is this immediate release planning, and Barry alluded to this as well. This is a part of the program that looks very specifically at the first 24 to 48 hours of release and helps people walk through the very specific needs they may have from the minute they walk out the gate of a correction facility to where they're going to be going, what they may need, who they might be seeing, and what supports they might need during, as Barry talked about, what could be a very risky and chaotic time for individuals. And then finally, the program includes a facilitated post-release service referral process to again help individuals link to these other social supports and life needs that they may have. Again, it could be around housing, employment, substance use treatment, etc. So how does Project START Plus incorporate harm reduction and overdose prevention? It does it in all 4 of these main areas. The assessment tools, most especially the behavioral risk assessment and the reentry needs assessment, both include questions specifically around harm reduction and overdose prevention, and I'm going to show you a couple of examples of that in just a minute. The goal sheets, as I mentioned earlier, are very personalized, so they can include harm reduction and overdose prevention goals, and indeed, if this is a real issue for somebody and some concern, an entire goal sheet can be dedicated to harm reduction and overdose prevention. In that immediate release planning checklist, it includes a section on harm reduction and risk reduction and potential material folks may need in that potentially risky time right at release. And facilitated referrals, providers are encouraged to look to access to harm reduction overdose prevention referrals that they may have and services they may have in their community, such as syringe exchange, syringe services, and Narcan distribution. And Emma will be talking a bit more about all of this in her next section. So, as an example, in the HIV behavioral risk assessment, here are a few of the questions that are included that specifically speak to harm reduction and overdose prevention. These are in the context of drug use with an individual when we're having a conversation with them about their intended behaviors around drug use. So questions about, do folks know about Narcan and naloxone? Have they discussed Narcan and naloxone with their drug-using partners? If you'll be injecting, where will you obtain your drug injection equipment? Asking them if they've used syringe service programs or know about these types of services in their communities, or if they've looked to reduce their risks in any other ways, such as cleaning drug injection equipment, limiting syringe sharing partners. And then again, linking it back into HIV and discussions about disclosure, and with overdose and harm reduction specifically around HIV disclosure to syringe sharing partners. In the immediate release checklist, as I mentioned earlier, there's a whole section on helping folks figure out what types of HIV, hepatitis, STD risk and harm reduction materials they may need. This may include things like Narcan and safe injection equipment. Project START Plus has also worked to integrate harm reduction and overdose prevention training with Project START Plus staff. We've worked in direct collaboration with the Harm Reduction Coalition to develop a complementary training for staff who are going through Project START Plus, and have worked to look specifically at the Project START Plus intervention and some of the messaging and activities and ways in which staff can incorporate harm reduction and overdose messages. Project START staff can also support naloxone access for people upon release. That's built into the intervention. And indeed, we've gone to the extent, in some cases, to actually have Project START staff trained and able to provide prevention education and access to naloxone themselves. So with that, I'm going to wrap up my section and indeed turn it over to Emma Roberts from the Harm Reduction Coalition, and she's going to go into a little bit more detail about harm reduction and overdose prevention as was started in the overview of Project START Plus.
Thank you, Katie. Hello, everyone. It's really good to be with you on this Friday afternoon from New York, depending on where you are in the US. So yeah, we were really excited to collaborate with Project START Plus providers to add the complementary training to the Project START training that we've provided with Katie and Barry. And I think people's response to being able to learn about overdose prevention and naloxone as part of the harm reduction-based services they were adding into their Project START Plus work was really well received. And I think it's interesting looking at the poll that you guys filled out at the beginning of the webinar that, you know, at the moment there's around 20 to 25% of you on the phone that are providing some kind of overdose prevention education. So that means that a lot of you that are on the phone, there's an opportunity here for you to really build out the kind of services and education that you're providing to people to help them to prevent overdoses, either for themselves or for their loved ones, or for other people in their community. To show you a few more statistics around that really build off of the ones that Barry gave us earlier. If you haven't already heard about it, it's all over the news. There is an opioid overdose epidemic in the US going on right now. We've seen a 5-fold increase in deaths between 1999 and 2016. We're awaiting the figures for 2017. We're not anticipating those to be much lower, if not higher. Many of those overdose deaths, about 2/3 of them, are attributed to opioids. And as you can see from the graph on the right-hand side, that is more specific in relation to people coming home from prison. In the first 2 weeks of coming home, the red bars show you that that's when people are most at risk of dying from an overdose. So this tells us that this is a really important need, and it's something that we need to be addressing for folks as they return home into their communities. And what the research also tells us that after a period of not using opioids, people's risk of death increases because of their loss of tolerance. They've not been using for a while, and especially with opioids, that loss of tolerance can happen over a very short period of time. Even if someone's in jail over the period of a weekend, their tolerance will drop quite quickly. So, from Friday to Monday, by the time they start using it on Monday, their overdose risks can shoot up dramatically. we've already seen that people leaving prison are particularly vulnerable, not just because of that loss of tolerance, but when people come home, say, after a long period of being away, they don't really know what the drug trends are anymore. There's new drugs on the streets that they haven't come into contact with before. They might not understand that if they are going to start using again, they don't need to use as much as they used before. And also, I think one of the biggest things of people coming home from prison is the fear and the shame, which often leads to people using alone. They're scared that people are going to judge them because they've started using again. They are scared of what might happen in terms of their parole. So often people end up using alone where there's no one to check on them if they do happen to overdose, and that increases their likelihood of dying greatly. So what we found is that, as you can see from that last bullet point on this slide, that we can do some really effective overdose prevention in under 10 minutes. I mean, we can take as long as we like, but we can provide people with basic information and knowledge and tools in less than 10 minutes. I ran a syringe exchange for many years. I used to do this on the street corner with people, and it can have a dramatic impact on their on risk reduction and harm reduction for that person. I need to mention fentanyl. Again, you're probably hearing a lot about this in the news right now. This has, it's an opioid that has entered into the drug use streams, and it's 50 times stronger than heroin, and it acts much faster. It's now becoming the leading opioid for fatal overdoses in many cities, including New York City, where I'm based. And it's not only mixed in heroin. What we're hearing and finding out is that it's being added to other things like pressed pills. It's been found in cocaine. It's becoming an increasing issue that we need to adjust our harm reduction messaging for people so that we can help them to deal with this new drug trend. And again, as I said earlier, people living in prison are particularly vulnerable, especially if they've not been, if they've been away for a long time and they're not aware of this change. So we need to add additional education, and there's been some things that we've changed to the way that we train people in responding to overdose because of fentanyl, basically in terms of getting naloxone to people much quicker, and also that the fact that they might need more doses because of the impact of the stronger opiate. And so we just really wanted to flag that because that's one of the newest trends that we're facing. And then, so as well as the work that we did with Project STAR, Harm Reduction Coalition has also been involved in a collaboration in New York State that was between the New York State Department of Corrections and Community Supervision, New York State Health Department, and ourselves. And what we did was we got approval at the state level to train soon-to-be-released people, regardless of their drug involvement. So they could have been someone that previously used, but they could be someone that's never used and has no intention of using. But we wanted to make sure that everyone was trained on opioid overdose prevention with naloxone, because the more people that know about this, the more people that carry kits, we're creating what we call a culture of safety across communities. So many of those individuals that we were training that were like, oh, I'm never going to go near this, or I never want to go near this again, we were able to say to them, well, actually, this is a skill, this is something you can take back and offer to people in your communities. And we've actually seen that happen. We've had an example of one of our trainees who went back into his community, has used his naloxone kit twice, has saved 2 people, even though he himself is not using. We're providing this community-wide response to the opioid risks. And so people are now, this is going statewide in New York State, people are offered kits upon release. It's an opt-out program, so people are offered the kit regardless with their belongings as they leave, and they can choose to not take it. But everyone gets offered it who's been trained. We felt that that was a better way than an opt-in, so that people don't have to remember as they're leaving to ask for their kit. They just get offered it automatically. And then, we, as Katie said, we've also been able to train Project STAR staff who were involved in supporting people as they come home, And that's also built out into supporting some of the programs in New York, like Women's Prisons Association, to actually become their own naloxone distribution program as well, because they felt that, as well as the naloxone that people were receiving as they were coming out, they wanted to complement that by being able to replace people's kits if they needed to, if they lost them or they used them, or offered them to friends and family as well. So they've developed, through the collaboration that we had with Project START, this new program as part of their services to provide naloxone for people on the outside as well. And so that's just a picture of some of our lovely trainees who were really happy to be in this photo with us because they were really excited about the training that they received. And since 2015, when we started this project, over 5,000 formerly incarcerated people have actually left prison carrying a naloxone kit. Just a little, for those of you, like I said, there's quite a number of you that are not currently providing overdose education on the phone, just so you, just for a little more, so you know a little more about it. Naloxone is a medication that people can carry to reverse opiate effects of sedation and respiratory depression. So basically, when somebody's going into overdose, they're experiencing respiratory depression, which means that they're not getting oxygen and they're dying of a lack of that. It does cause sudden withdrawal for people who are using opiates regularly, so it can lead to people feeling unpleasant when they come round and in withdrawal, but we'd rather have that than somebody die. You know, when we train people in more detail, we train people in how to respond to that, to the fact that people are feeling very very disorientated and uncomfortable when they come round. But there's no potential for abuse. This is not an addictive medication. There's a lot of, in the media, there's a lot of information flying around that's not fully accurate about naloxone. And that's one of the things. It's not addictive. It wakes the person up who's overdosing in about 3 to 5 minutes. Now, with fentanyl, it can take a little bit longer. It can sometimes, you know, take more than 5 minutes. So what we're doing in that is we're providing people with multiple doses of naloxone. So we used to provide them with 2. Now we're providing people with maybe 4 to 6, so that if someone has taken fentanyl on board, they have more of the medication to be able to respond. It works for about 30 to 90 minutes on someone, so it gives them a chance to wake up, start breathing again, and get the attention they need. There is the possibility that someone could go back into an overdose after that 90 minutes, so that's why it's really important that when we train people, we teach them how to monitor somebody for a period of time afterwards, especially if they're not going to the emergency room. But it's very safe and it's very highly effective. And basically what it does is, there's this analogy that it's the wrong key stuck in the lock. So basically the naloxone replaces the opiate on the brain's receptor and becomes this key that's stuck in the receptor that's the lock, and it stays there for about 90 minutes. And once it's phased off, the opiates can return back to the receptors. It's routinely been used by EMS for a long, long time. It's been around for many, many years. But they often give it in larger doses than we have for lay people. It doesn't do any harm, as it only acts on the opioid. So if somebody's having some kind of other medical emergency going on, it's not going to be impacted by naloxone. And if we're looking at someone and we have no idea why they're unconscious, it's at least something we can try until other emergency services arrive to investigate what's going on further. And just for those of you that maybe already doing overdose trainings, or particularly if you're thinking about doing overdose training, on the left-hand side of the slide, you'll see what are the training essentials. So when we train people, we need to explain to them what naloxone can do, how to recognize an overdose, and we teach people how to do what's called a sternal rub, which is where you actually rub your knuckles on your breastbone or on the person's breastbone to ensure that they are fully unconscious, what actions to take, which includes calling 911 for EMS, talking to people about the Good Samaritan laws that may be in their state. In New York, we have a Good Samaritan law. Many, many other states have now passed Good Samaritan law in response to the opioid epidemic and overdose rates, so that people are protected through the Good Samaritan law if they call 911 for certain things. For example, if there's drugs present, or if people are under 21 and there's alcohol present, they can be protected. So it's a way to encourage people to feel safe in calling 911. And then also we teach people in training then how to administer naloxone, how to put someone in recovery position, and then how to report and get a refill. So that in New York State, we used to fill out a form if people told us they'd used their kits, so that we could submit that anonymously, so that we could track, how naloxone was being used. So that's the piece on the left-hand side that you can do probably in under 10 minutes, as I said earlier. Other additional things that are always really useful to do, and also for those of you on the phone that aren't currently doing any overdose education, even if you don't access naloxone right now, you can do some of this education to teach people. So you can teach them about the risk factors for overdose, so loss of tolerance, the impact of mixing different drugs, and the risks of using alone, and how to address that. You can also teach people about resuscitation, so using rescue breathing, even in the absence of naloxone. If you are doing rescue breathing for someone, you are putting oxygen in their body to keep them alive. And if you know full CPR, then you can do chest compressions if appropriate. But the main thing we've taught people over the years is rescue breathing, and also teaching people about the Good Samaritan law and the features of that that protect them. So that's just a little bit of information, especially for those of you that might be thinking about incorporating in this. Even without naloxone, you can start to add this education to the services that you're providing and the case management that you're giving people to help them reduce the chances of overdose. So that's me finished. I'm also going to hand over to my colleague Michelle from Southern Tier AIDS Program, and she's going to tell you a bit more about examples of how they've also done this in the field.
Thanks, Emma. So my name is Michelle McElroy. I'm from the Southern Tier AIDS Program, and we currently offer several services related specifically to overdose prevention, harm reduction education, and corrections. So the first thing I'm going to talk about is our Corrections to Community Care Grant, also called the Criminal Justice Initiative. And this is a New York State Department of Health grant that facilitates entry into prisons within the New York State Department of Corrections system to provide in-facility services to individuals who are housed there. Those services include in-facility HIV, STD, and Hepatitis C peer education training sessions, so people can complete a peer certification training process in order to then be HIV peer educators within the facility, and they disseminate that information to individuals who may not have the opportunity to attend educational sessions with staff, or who may not be willing due to stigma to attend educational sessions or one-on-one risk reduction intervention. We also do pre-release linkage and navigation for individuals who are incarcerated in the facilities who are living with HIV and AIDS. So individuals who disclose status to us, or individuals who are referred to us through the medical unit of the Department of Corrections are able to receive enhanced discharge planning services through this grant to reenter the community. So we have staff who are trained to go in and work with the ORCs in order to facilitate enhanced discharge planning to help ensure successful reentry. So that includes things like coordinating HIV medical care on the outside, assisting internal and external parole with housing negotiations and approval, making sure that individuals are also connected to behavioral health services if they require those, and also facilitating any other medical or behavioral health care needs they may have once they reenter the community. We also do a comprehensive risk assessment for all of those individuals who are reentering the community in order to tailor the plan and coordinate additional services that may be required. So for example, if someone indicates that they need to return to harm reduction programming and services upon release, we will make sure that they have the information to be connected to those resources when they reenter. There are multiple syringe exchange programs throughout New York State, so even if someone is reentering a community that was not their home community, we're often able to link them with a harm reduction provider that's going to be in the region where they will be reentering. And of course, all of this enhanced service provision helps to ensure people's success upon community reentry. It also helps to ensure that someone will remain adherent and virally suppressed on their HIV medications, because they are discharged with a short supply of medications, but this make sure that they already have a standing medical appointment upon release, so they don't have to worry about coordinating that in order to get in and continue care. And the staff also facilitate them applying for ADAP or starting their Medicaid reactivation process prior to release, so as to make sure there's no gap in coverage. Within the peer training program in facilities, we use a harm reduction model for all of our service delivery, but we also integrate that into the peer education and training. So as several of the other presenters have mentioned, there are a large number of individuals in a correctional setting who themselves don't have a history of substance use or don't specifically have a history of injection drug use. But we make sure that part of the peer education and training process is to familiarize everyone with harm reduction and harm reduction services so that they can be a resource for their community upon reentry and be able to disseminate that life-saving information to other individuals that they may encounter. So we talk about harm reduction services that are offered in syringe exchange programs and also at HIV service organizations. And we try and support understanding and incorporation of those risk reduction methods for individuals who are currently incarcerated. We also offer one-on-one sessions for people who are interested in doing a comprehensive risk assessment while they're still in the facility and talking to them about risk reduction strategies if they have current risk that they are not able to discuss with the medical services in docs. Again, it's really critical that the peer educators have this information to give it to other individuals within the facility, because there are a certain number of people who are never going to be able to access the educational sessions or peer training because of facility regulations, because of their own barriers, and also because of stigma. So even if they potentially could access those things, they may choose not to because of their own concerns. Particularly individuals whose status is not known to docs, that has not told the facility that they're HIV positive. Although the education courses are often valuable to them and they might be interested in attending, they may have concerns that that would lead to a status disclosure for them personally, and so they may not choose to engage in that particular service. Overdose prevention is incorporated into all of the educational sessions we do in facilities. So that's not only the peer training, but it's also the basic orientation, HIV, Hep C, STD overview we do for all inmates who are coming through, so that they have that base level of information for themselves and also to share with others. So it's good for the peers to have that, but it's also good for everyone to have that basic information that they may not have received elsewhere, or that they may actually have received false or misleading information in another context. Once individuals actually re-enter into the community, we have a separate grant that allows for us to facilitate individuals who are at the greatest risk for recidivism based on an assessment that's provided by the Division of Criminal Justice to assist men and women both who are returning to Broome County from correctional facilities across New York State. So that is a designated grant for Broome County, which is one of the counties upstate where there are a very large number of re-entrants. So within Broome County, we serve individuals and we do a whole host of wraparound services for individuals who are re-entering the community to try and assist them with sort of rebuilding their lives and successfully settling into the community where they're re-entered. We have partnered with over 40 different community agencies in Broome County and surrounding communities to do referrals, to help facilitate rapid turnaround entry into behavioral health services, and we also do specific dedication of resources to that program to help make sure that people have access to transportation to get to appointments, and that they also have several free educational opportunities within the first several weeks of their re-entry to attend that not only are supported and approved by parole on the local level, but also offer them some skill building and coping skill development activities so that they can manage that particularly stressful and risk-filled time. Within that reentry program, all of the individuals are offered the opportunity to receive a naloxone kit. Everyone gets opioid overdose training, and we also trained all the local parole officers. We found that it was necessary to start the training with parole, and then once we had trained the parole officers, they understood the purpose of the program, they understood the benefits of the medication, and the fact that it's not really a risk or a controlled substance otherwise. That allowed us to have much more buy-in for the training of the parolees moving forward. So we attempted to start with training parolees and then realized we had to sort of take a step back and start with the parole officers themselves and do some education on the system level. And then it was pretty successful to move forward from there with offering the training to all parolees and distributing kits. We also found that offering the training with in conjunction with parole officers being in the room was fine, but people were reluctant to take kits in front of their parole officer, even though their parole officers also have kits and have told them that they are legally allowed to have them, and it's not a violation of their parole to do so. Many people were reluctant to take them in front of parole, so we now actually do the training with parole present, but we do kit distribution in another context when they get information about care management and other community referral opportunities so that they can take that kit in a more comfortable setting. So again, finding the inside advocate, we found this when we had to train parole before training parolees. And likewise, this is also true within facility, of course. Inside the facility themselves, because we offer a variety of different services, we have found that we need to have different contexts depending on the service we're offering. So when we're talking about linkage and navigation services for people who are reentering and successful discharge planning, there are really several different staff that we have to involve in that process to make it move smoothly, and it's important to know who your go-to person is within each facility. We have also found that in different facilities, that person can have a different title. So it's important to know who it is that you really need to go to in order to reserve that confidential space, who it is that you really need to go to obtain that gate clearance or a standing pass, and who it is that you need to go to, perhaps a separate person, in order to obtain authorization to bring in all those educational materials and confidential files that are going to have to come through security. The successful programming for OOP across New York State also found that training the correction officers within the facilities first was more successful to then roll out training for all of the individuals who were actually themselves residing in the facilities. Because many correction officers, again, once they understand the purpose and intent of the program, and they themselves are coming from communities where they may have seen overdose deaths, they may have family members, extended family and friends who've been personally impacted, it was easy to see, once they themselves had the training and understood the purpose of the program, why it is that that sort of should be rolled out across the New York State prison system. And self-selected champions always help to support the work of peers and staff. So staff volunteers conduct trainings within the facilities for OOP because they were the individuals who were the most invested in rolling that program out and making sure that other corrections officers were to be trained. Originally, the Department of Health was doing some of those initial trainings in the Harm Reduction Coalition, and then what they moved from that model, because of the capacity concerns to train every person in the Department of Corrections system, instead they have found these champions within each facility who are now able to take over the training responsibilities for their peer staff, and that has been very successful, and it also has facilitated, new hires and other individuals being able to schedule and receive that training in a much more rapid turnaround time than if it had to be done by external parties. And I'm actually going to turn it back over to Emmett.
All right, thank you, Michelle, and thanks to all of our presenters. Before we dive into the Q&A, I just wanted to highlight a few resources for everyone who's joining us today. Just remember the Q&A, you can enter your questions in the lower right-hand corner in the Q&A box. We've got a few rolling in right now. So as things come up, please enter them, and we'll do our best to answer them in the next 30 minutes that we have. So on this slide, you'll see if you're interested in learning more about Project Start Plus, please reach out to the bridging group. Again, they offer training and capacity building. And if you're interested just in some of the background research, there's a really great literature review on key components for successful linkage programs that's available here. And again, you will be getting the slides in about a week on our website, and they'll be emailed out to everyone who registered for the webinar today. If you haven't gotten your fill of information on syringe service programs and harm reduction, the Harm Reduction Coalition and AIDS United are here to help. So again, you can reach out to the Harm Reduction Coalition and AIDS United for training and capacity building, as well as resources around syringe service programming and harm reduction. And just wanted to point out a few things that AIDS United can offer, is that we have a fact sheet about improving the health of people who use drugs and how syringe service programs can assist there. We also have a resource about supporting individuals returning to the community from jail. And then finally, we have our Syringe Access Fund. We have an open enrollment for a grant. So if you're interested in, getting a little bit of support around some of the harm reduction work that you're doing, that is also a resource for you. And then finally, the Centers for Disease Control and Prevention have SSP guidance and related resources, as well as the World Health Organization and United Nations. All right, and again, if you're in need of technical assistance, if the wheels have been turning on this call, please do reach out and email us at siba@aidsunited.org. We will be able to help assess kind of what's going on with you and do our best to tailor trainings and technical assistance that work for your organizations and for your communities. And so we've come to the Q&A period. So I'm going to start off. We did get one of the first questions I want to ask. Barry, you talked a little bit about kind of folks first entering correctional facilities, coming out, and then going back in. And so I'm wondering, can you maybe speak more to the differences in supporting people living with HIV who were diagnosed prior to incarceration versus those who were newly diagnosed since they entered prison or jail?
Sure. I think Katie mentioned a bit about this, just how different that is. When people have had experience of living with HIV in the community, they've maybe have know what ADAP is, know what HOPWA is, know what have been to a clinic, getting care, getting treatment. The treatment protocols, think about it, like, in the community, whether you have HIV or anything, you go to the doctor, you get a prescription, you go fill it. Sometimes that prescription is filled at the doctor. Sometimes you have to do it, you go into a pharmacy on your own. In prison or jail, just think it's like very, I think maybe the best term is passive, in that sometimes there's a cart going up and down the housing unit passing out the meds, so you don't have to do anything. Sometimes it's a keep-on person. You get a week's worth of medication. Sometimes it's directly observed therapy. Sometimes there's a pill call. You have to go to a window, and you get all these issues about about outing, about what kind of, what medications people are picking up. But so somebody who has never lived outside with HIV really has to understand and has a whole new learning curve of how to live with HIV in the community, just like as if they were just diagnosed in the community. Because on the inside, the treatment, the care, the medication is so different. I'm using the medication piece as an example, but there's a lot of other things as far as disclosure, as far as risk behavior. What your experience is on the inside is going to be very, very different once you get out. So this kind of linkage to care, it's a good question. Let's expand the question, because it's not just about linkage. It's about living with HIV in the community for someone who just learned that they have it on the inside versus someone who knows what it's like.
Thank you so much for that, Barry. I have gotten a few different questions, and I'm going to send these ones over. So Katie, can the assessment tools that you mentioned from Project Start Plus be shared? And even further, can you speak a little bit more to the process about getting Project Start Plus implemented in an organization?
Sure. So first, yes, the assessment tools can be shared. We actually are in the process of getting them posted to CDC's website, effectiveinterventions.org, which you can find further information about Project Start Plus, along with many of all of the tools. We have just finished CDC clearance on these materials, and they're still in the process of getting posted to the website, but they should be there shortly. And indeed, the assessment tools plus many other client or intervention tools will be there. So hopefully, Emmett, maybe we can post that website website address somewhere to the whole group. And in terms of getting more information about Project Start Plus and implementing it, I guess there's two ways to do that. Either if folks are already in the field and doing any kind of linkage to care work and or working in correctional facilities, you can certainly submit a CRIS request for technical assistance, as Emmett talked about on the slide previously. And you'll see our email addresses coming up here, and we can work through AIDS United to try and provide some technical and capacity building assistance for folks. As well, there is training on Project Start Plus, training and facilitators that's available to people, especially if you have CDC funding either directly to your agency or through state health departments. And again, that effectiveinterventions.org website is the portal to request training. So if folks are interested in going through a training, it's a 3-day in-person training on Project Start Plus. Again, I encourage you to visit the effectiveinterventions.org website and sign up, and we can put you on a list so that you get notification of upcoming trainings.
Great. And Katie, do you have, just off the top of your head, any upcoming trainings of facilitators coming up for Project Start Plus that folks should know about?
Yeah, I didn't go there because we have one going on next week in Los Angeles, but it's pretty much closed at this point. But we will be scheduling more trainings, and after probably coming up in the spring or so. And one thing that does help us in terms of knowing when and where to schedule the trainings is the level of demand and where that demand is. So again, if folks are interested in the training, I suggest you sign up, and that'll put you on a list, and then we can start to plan. But there will definitely be at least another Project Start Plus training of facilitators coming up, probably spring or summer, and location to be determined.
Great. Thank you so much for that, Katie. I'm going to send the next question over to Michelle. So Michelle, you talked a lot about your work, specifically, working within correctional facilities. So have you experienced any pushback about bringing your trainings to correctional facilities? And if so, what are some of the best practices you've learned around how to manage those relationships?
Sure. So I think that the inherent conflict in our work is that we will always find people within the correctional facilities who are very supportive of what we do and understand sort of the bigger picture pieces of public health, community health, why successful reintegration matters to help prevent recidivism. But there are always a cohort of individuals within correctional facilities that don't really understand the larger intent of the work and feel as though it is offering an opportunity that perhaps the individual should not have, I think. So again, I think that this piece about identifying who your key resources are in a facility is really, really important. We have worked in several of our facilities for a large number of years, and so coordinating programming in a facility that we've been in ongoing for more than 15 years is much less challenging than when we added 3 new facilities to our grant this year in the fall. And we are still looking to identify some of those key players in one of those new facilities. And again, it really does vary so much from facility to facility that I encourage people to sort of know by title who is supposedly in charge of which programs and services and facility, and start with the right person. It's important if the person who really should be the person that you talk to is the deputy of programs, that you talk to the deputy of programs first and allow him or her to direct you to their designee if they wish to do that, rather than sort of going to the person that may be the easier access person for staff. Likewise, within the medical unit, it's possible that the nurse administrator is the right person, but it's also possible that the nurse administrator is not the right person. So if we're not confident about who we need to go to in a facility, we try and have someone at a facility that we already have a good relationship with link us to the staff at a new facility, because they often have a good understanding of how that other system functions if it's different from their own, and also who at that other facility will be a good resource and who is a person that may not be a good resource. So I think using people that you already have a relationship with is important. And if things become very challenging within one specific facility, we sometimes try and call a meeting of multiple people with that title across several facilities. So if we're having trouble with one particular director of programs, not really feeling like peer training should be happening in the facility, then we might try and have multiple directors of programs come together for a meeting with our program staff, so that that director of programs can have the opportunity to learn from their peers and hear the ways in which those services have been valuable in other facilities. We try and say to our staff, as in all settings, the best way to convince someone to help you is by them seeing you as a resource for them. So if the nurse administrator is really pretty busy doing a lot of things that she has to do, and she feels like it's a burden to have to schedule a room for you, that's not a good way to start the relationship. If there's a way that you can facilitate making her life easier, then that is a good way for someone to feel like you're in a partnership with them, and not just that you're asking them consistently to add another responsibility to their own job duties.
Where are the effective?
That's a really great point, Michelle. I have a question. It's a little bit different, but kind of along the same point. And this is for Emma. So Emma, can you speak to how you've engaged parole officers and local law enforcement in implementing harm reduction and overdose prevention for people returning home from incarceration outside of correctional facilities? So I'm thinking, we asked Michelle about stakeholders kind of within correctional facilities, but how have you engaged, community stakeholders outside of those facilities who fall under kind of this law enforcement umbrella?
Thanks, Emmett. Yeah, I think it kind of piggybacks off what Michelle was saying. It's really, what you said, Michelle, is so on point. It's about finding the right person to connect with. So who can be that champion, as Michelle described. So when we first started out, we had a real champion within Departments of Correction who was like a superintendent of a number of facilities here in New York, and he has been a superintendent for many, many years, so he has a lot of connections, not just within New York State Department of Correction systems, but also within parole. So he was able to, and beyond. He's very well known, he's very well respected. So he was our champion, and he led the cause really, and we were able to, through him, then get connected to the right people in parole. And I think, in Michelle's presentation as well, she spoke really, really well about the systems piece, about we want to get this into the hands of people who use drugs and community members and their family and friends, but also, the people in the systems that, especially for people coming out from prison, so like training the parole officers and making sure that you connect with the right person there, who's the right manager or the right lead, and similarly, we trained police officers a long time ago in New York City to carry naloxone, and when we did that, it was about connecting with the right person within the academy, and eventually it turned out to be the training officers within the academy that we trained, who then became the trainers to train their staff to carry naloxone as police officers. I know that when I ran programming, the other people within police precincts that I connected with, again, with the training officers, and it speaks to what Michelle was saying about not adding a responsibility, but the training officers often really like collaborating with us because we're supporting them to do their job. We're helping them to achieve what they need to achieve. So again, it speaks to finding that right person, and often the right person to then speak to each other, parole officers will listen to other parole officers, police officers will listen to other police officers who can tell them this is a good thing, this is not going to add to your jobs, this is going to enhance what you do. So yeah, you're kind of similar to what Michelle was saying. It's really finding the right people and helping them to see that this is really supporting them to do their job.
Absolutely. And so I have a question that I'd like to pose to Michelle first, but I would love to hear from some of our other panelists as well. One of the key components of harm reduction is participant involvement. So folks who are directly impacted, specifically by drug use, by other harms, should be involved in creating programming and doing some of that education, much like you did with Southern Tier AIDS program. So Michelle, I'm just wondering, can you talk a little bit about some of those key best practices for meaningfully involving participants to kind of move your work forward?
Sure, we can speak a little about that. So I think that the use of peers, the very comprehensive peer training program, is one avenue to sort of make sure that there is ongoing involvement from individuals who are going to be served by the program. After our peers finish their training, the individuals who are selected to move forward as the peer educators come to group supervision every other month. And that's an opportunity for them to get updated information, practice their speaking skills, and talk about boundaries or concerns that they may have. But it's also really an opportunity for them to give us feedback about how we should improve the peer training. What kinds of supplemental materials are useful for them? What kind of questions do people have when they're doing sessions, in the yard, or when they're doing an orientation class? What kind of questions do people have that come up over and over again that we could give more detailed information about, or that we should really focus in on in order to make sure people have accurate information and we're dispelling those common myths? So I think that's one really important piece. And the other piece is that as an agency, we have human resource and agency personnel policies that allow us to hire people who are formerly incarcerated. I've worked in lots of human service places where even though they served individuals in incarceration settings, they wouldn't hire anyone who had any criminal history. So we have a policy that allows us to hire people who are formerly incarcerated by, on a case-by-case, evaluating the nature of their crimes, the nature of the work that they are applying for, how long it's been, whether there's a concern about their ability to do the job or their ability to serve people well in the role they're applying for. And that really facilitates us being able to bring people in as staff and also paid peers who know firsthand about lived experience, who maybe even have been through some of the programming themselves, and now on the other side have the opportunity to meaningfully contribute and direct program redesign and improvement.
All right, thank you for that background. That's really helpful. I have another question. And so this question has to do specifically with a graph that Emma showed. So I'm actually going to just scroll back there really quick. But let me see where that is. Here it is. So Emma, on this chart, it showed that the rate of overdose deaths and non-overdose deaths within the weeks of release. If you notice, there's a mini spike in non-overdose deaths around weeks 4 to 5. Can you speak to maybe some of the causes of this spike? If not overdose deaths, what is kind of happening at that 5th week from release?
I don't know. I'm going to be very honest and say I'm not sure. I looked at that myself. So I think what I'd like to do is go back and consult with some of my colleagues to find out what that might what that might be about, because it is interesting. And I don't really want to hazard a guess at this point, but we could definitely, do a bit more explanation of that and send that out with the slides. Does that sound okay, Emmett?
That's perfectly fine. That's something that we can include with the webinar recording, but I think that would be really helpful. All right.
This is Katie. Can I just jump in for a minute? And I think it'd be great if Emma followed up. But I also think in our years of working with folks after release, we definitely have seen in that kind of month to 5 weeks, that 4 to 5 weeks period of folks kind of having the quote-unquote honeymoon phase end, and people kind of tend to sometimes have some immediate plans, immediate supports, but then kind of the reality of ongoing life on the outside starts to show up a bit more at about the month, 4 to 5 week phase. So I don't know if that might be reflective of suicide or kind of getting more involved in risk behaviors on the outside, whether it's gun violence or such. But we've definitely seen trends where life just really starts to pick up at about 4 to 5 weeks. So that may be part of what's going on there.
Thanks, Katie. Yeah, I was thinking that, but I just didn't want to guess that somewhere. But you're closer to some of that than I am at the moment. So yeah, I mean that's what was in my mind. But I think I'd like I can go back and look at the research behind the graph to see if they gave even more specific examples of what's going on for people there.
One other one, if it throw out there, is sometimes people get released right into a treatment program for a month. So this could be showing what happens when that month is up.
All right. So I'm not seeing any more questions coming in, but I did just want to give a chance for Katie and Barry to potentially talk about the network of folks that you have around Project Start Plus.
Sure. The third Friday of every month, which today happens to be it, Katie and I host a monthly network call of people who are implementing Project Start Plus or other linkage to care. I mean, the focus is Project Start Plus, but there are people who call in. We do have some sometimes expert speakers come in to facilitate the call. Please let us know if you're interested. I think the next slide or two will be how to contact us. So feel free if you'd like more information about Project Start Plus. If the surveys instruments do not get up on the CDC website, by all means contact us. We're more than happy to talk with you about how we can support your efforts on linkage to care. Thank you.
Great. And so we would just like to acknowledge the Bridging Group, Harm Reduction Coalition, and Southern Tier AIDS Program for their leadership in developing the content and their delivery on this webinar. And like Barry said, you can see up here you have every presenter's contact information. So you can reach Katie and Barry at the Bridging Group, Emma Roberts at the Harm Reduction Coalition, and Michelle McElroy at Southern Tier AIDS Program. And just as a reminder, this recording and these slides will be available about towards the end of next week. I want to thank Katie, Barry, Emma, Michelle for leading this webinar today, and so many thanks to all of you who joined us on this Friday. Have a great weekend. Bye. Sorry about that, Katie and everyone. Katie, go ahead.